and this is about supportive care for patients with GvHD, both acute but also chronic GvHD. And I guess it's maybe more difficult in chronic, but again, I'd love to hear from you. Obviously, we won't be able in 15 minutes to handle any kind of supportive care. I think maybe I will refine my question. In your experience, in your practice, what are, for instance, the one or two supportive care fields where one needs to pay attention when it comes to acute GvHD and when it comes to chronic GvHD? Because otherwise it's a shopping list, you know. We need to pay attention to many things, including physical activity and physiotherapy and everything. And everything is important, I think. Robert.
Yes, I would like to mention a supportive care intervention that might be interesting. And this is GLP-2 agonists. There's a study ongoing with apraglutide. Actually, it has finished recruitment, and this was in the therapeutic setting. That's a different situation. But what we have done also is that we had patients who had survived the acute phase of GvHD, and they suffered from malabsorption. They were alive, and GvHD was, the inflammation was not so dramatic, but they never had a raise in their albumin levels, and they were sarcopenic. So they had muscle wasting and so on because of the long steroid exposure. And what we did is that we treated with teduglutide, because apraglutide is not available right now. And we saw that we can improve absorption in these patients. And I would call this not a GvHD therapy, but rather a supportive care intervention, because we improve the nutrition status of our patients. This has not been tested in this study, because the study is for acute GvHD as a way to improve response. But I think this is an intervention that comes later, when the acute phase has been survived and the patients suffer from the long-term side effects of the therapy and of long-term intestinal damage that we can repair possibly with teduglutide. Maybe for those who were not involved, teduglutide is a GLP-2 analogon. GLP-2 is an enteroendocrine hormone produced by L cells in the GI tract. And teduglutide is already approved for a disease called short bowel syndrome. And short bowel syndrome means that a part of the bowel has been removed for different reasons. And then these patients suffer from malabsorption. And so the gastroenterologists have been using that already for over 10 years. And now we are testing it now in the GvHD, intestinal GvHD setting, basically.
Super. Thank you very much. That was my question. I was about to ask you, Robert, to highlight to our auditors, because not everybody may be familiar with this, but thanks. Thank you so much. You explained this. Attilio, you opened your microphone.
I completely agree with Robert, because the nutritional status is pivotal and it's critical, particularly in patients with chronic GvHD, but also in patients with acute lower gut GI GvHD, because we can lose some patients with acute lower GI GvHD due to the insufficient and suboptimal supportive care in this setting. So I think that this aspect, particularly before transplant, should be considered, because many patients receive allogeneic transplantation in a suboptimal nutritional condition.
So can I, while asking the other colleagues also when you're going to answer, because you're bringing this nutrition issue, there was this randomized trial published in Blood Advances, I think from Italy, maybe 3 or 4 weeks ago, Paolo Corradini, showing that maybe what we've been doing historically about all of these kind of...
No difference, no advantage by using artificial nutritional support has been observed in patients. This was a study in a small number of patients, but this suggests that the nutritional support by using parental nutrition is not effective. But it is,
no, Attilio, I was alluding to the study randomizing normal diet versus very restrictive, clean, cooked, blah, blah, blah diet. And in neutropenic and not only transplant patient, and it proved there's absolutely no difference.
yes, there was no difference in a restriction diet, but the pre diet was similar in terms of there was a trend in favor of patients receiving pre diet. There was a small number of patients, but the advantage of the study was that it was my knowledge, the only randomized study.
Excellent. Who want to jump in? Amin.
Yeah, the nutritional is fascinating, and I loved Robert's paper, the preclinical model of the shortcut agent. That was fascinating. In the chronic GvHD setting, two therapies that I think are super helpful in targeted populations are for patients with contractures. We have a program with a very special occupational therapist who builds bivalve casts for patients with contractures to improve mobility, and you progressively build the cast such that you extend the joint of interest progressively, and they wear it throughout the day. They can take it on and off because it's a bivalve, and it really we're formally looking at the degree of improvement with just that intervention in patients with joint contractures, which, as you know, are a very challenging group to treat. The second supportive care therapy in the chronic setting that I've been amazed as to outcomes are we have a pelvic floor therapist who now works with us in the clinic for women and men who have pelvic floor issues, but specifically in females with genital urinary GvHD or vaginal GvHD. These are PhD level physical therapists who've studied pelvic floor and have a subspecialty in that. And we have seen amazing results in women who've had severe agglutination and stenosis of the vaginal tract and recurring and improving organ function, and hope to highlight their efforts in the future.
Superb. So let's continue on this so-called nutrition or nutrition-like support. What is the situation in Turkey, Mutlu? Is there any specific practice, or Ali, a special Mediterranean diet?
Well, I have very little to add to the colleagues in this aspect. Actually, the acceptance of oral feeding is through NV or NG feeding is very, most patients are very reluctant to have oral feeding with a tube, and we frequently have to go with parenteral nutrition in these patients. But there is another aspect that the nutrition I would like to highlight in terms of supportive care is infectious complications, particularly CMV reactivation. So in the pivotal trial for letermovir that established this drug as a standard of care for CMV prevention in high-risk patients, the duration of letermovir is 100 days. And currently we are using letermovir beyond day 100 in patients with acute GvHD on corticosteroids, but I think that we need some kind of standardization and clear recommendation in that setting for how long it should be used or it can be used.
Thank you, Ali. Who would like to jump in? Well, I can tell you when it comes to nutrition or nutrition-like, as you probably know, we have this high interest in the field of microbiota modulation and trying to restore or enrich, I would say, the microbiota. And interestingly, this morning we had the release of the DSMB results about a very positive, favorable benefit risk for the first group of patients treated in the phase 3 pivotal trial called ARIS in Europe. Obviously, I don't know, I just saw a press release. I'm not part of the DSMB. But also, what is also in terms of supportive care, if we can call it supportive care, we have just launched a randomized phase 3 trial, placebo-controlled trial of oral microbiota product, an allogenic multi-donor product. And actually, my best guess is that the first 2 patients are already included, one in, I think today in Germany, and one in France. And I believe this is part of the so-called maybe nutritional supportive care or so on. And of course, the goal is to try to reduce the GvHD incidence, but not only the GvHD incidence, because this phase 3 randomized trial called PHOEBUS aims to improve survival, because we know the microbiota, thanks to the work of Marcel van den Brink, Jonathan Pellet, and many others, we know it can act and work from different angles just to update the community about this issue. Yibin, any thoughts on supportive care?
No, I mean, I've enjoyed the discussion. I mean, I agree. These are important areas, focusing not just on immunosuppression or specific pathway inhibition needs to be done to achieve the ultimate outcomes. We're involved with Robert's GLP-2 trial and look forward to those results. I believe protection or support of intestinal stem cells is crucial to any good outcome in GvHD. And I'm not sure how we optimally do that, but it's gratifying to see avenues actually exploring that through stuff like GLP-2, stuff like the microbiome. And we've done our own sort of pre-FMT type of things to try and maintain the diversity as well. But I think, I think it's tough with all these interventions to prove cause and effect. I think carefully designing clinical trials and thought into the primary endpoint of these things will be crucial to figuring out if we actually prove that they're helping.
Thank you, Ben. And actually, just to highlight to those listening to us, if they want to dig a little bit deeper into this, the potential role of glucagon-like peptide 2, there is a lovely comprehensive review by you, Robert, and Ibn in the British Journal of Hematology last May, if I remember well, and it's easily available. So you guys, I mean, those listening to us, if they want to get more information, I think this review is amazing. Thank you. Oh, Mutlu, here you are back. I can see you there. Oh no, he is maybe okay. Arnon, any thoughts on supportive care?
Is that we are using less TPN that we used to use more in the past because of infection and thrombocytopenia. So in the beginning, many years ago, some years ago, we were more using it more frequently. And other than that, we don't have an interesting study. No, nothing, smart to add to yeah, the thermovir 200 days. I mean, everybody agrees this may go. I mean, most of us will agree, but then they have rebound and late infection. We see CMV after you stop the letermovir. So, I mean, I agree with Ali for that, and basically this is it.
Thank you, Arnon. Much appreciated. Can I bring the vaccination issue regarding supportive care, especially for chronic GvHD patients? This is really timely because, at least here in France, there are now campaigns to get vaccinated again, have a sort of a booster against COVID-19. So what are the recommendations in your countries or your institutions? I know it's a moving target. Attilio, any thoughts?
So, as for the same topic, so to widen the topic outside the nutritional status and in the setting of chronic GvHD, of course, the supportive care should be considered also for infectious complication, because this patient should be evaluated also in long-term outcome, particularly for infection due to gram-positive bacteria, and in cases of patients, particularly patients with lung GvHD, the continuous lung infections, and this is a real problem for supporting care of this patient, because many patients with both need supportive care, which needs also physiotherapy and treatment. We started to collaborate with pneumologists, particularly patients with frequent lung failures, with the same approach used in patients with mucormycosis, because these patients are prone to logistic complications due to the difficult expulsion of secretion, bronchial secretion, and this is a practical aspect that needs a specific support care, which is not based only on physiotherapy, but also sometimes invasive measures. This is our preliminary experience, which is positive in this sector. So I will focus this aspect in this subpopulation, which is a small population, but is a challenging population, patient with loss.
Thank you very much, Attilio. So what I can say in our practice these days, one of the priorities is about physical activity and exercise beyond physiotherapy. Now we have sport coaches actually coming into the ward, but establishing programs to rehabilitate in terms of physical activity the patient. And now the French national health system actually reimburses. So you can write a prescription that this patient needs this coach, etc., which is quite amazing these days. So if there are no further thoughts, maybe
we have some. Sorry for interruption, but We have some preliminary positive results with bronchoalveolar lavage in patients with frequent repercusation, and many patients respond to this measure, which is not only a diagnostic measure, but also can be a therapeutic measure.
Okay, thank you, Attilio. So I was just saying that the supportive care topic is a very broad, large topic. It can take us hours and hours. I think we'll have the opportunity to discuss this in other round tables. But definitely it looks like that there is a lot of interest about nutrition and nutritional support, whether it is about increasing absorption, whether it's about modulation the microbiota, whether about it's which is the right route to use to deliver nutrition, or whether it is about using drugs to facilitate absorption, or even simply diet selection and maybe changing some of our very conservative practices.